Hi, my name is Tim Cohen, and welcome to Vital Conversations presented by Focus Solutions. Here, we talk to healthcare leaders from all over the industry about what's going on in their corner of the world. And I'm very pleased to have as my guest today Andre Beach. Andre is the Chief Operating Officer of Denver Arthritis Clinic. Andre, welcome to Vital Conversations.
Thank you so much for having me. I appreciate it.
Hey, before we jump into our topic today, tell people just a little bit about Denver Arthritis Clinic, just to give them a sense of who you guys are, specialty, scope, providers, those types of things.
Yeah, so Denver Arthritis Clinic we are the longest standing rheumatology group in Colorado. So celebrating our 50-year anniversary today, 11 physician group. And our goal is to provide premier rheumatology care to the community and really focus on quality patient centered care.
Awesome. Before we get into our topic today, your background is worth noting. Um, you started in healthcare literally at the bottom of the ladder. Tell folks how your mother got your career going in healthcare.
Yeah, my mom got me started on this crazy track. So I was about 13 years old. My mom was clinical manager in a OBGYN group in Colorado Springs. And so I was coming in, helping with medical records, chasing down charts, filing papers, doing things of that nature. So yeah, so I got an early entry at the very bottom. And then when I was in college, came back in a temp job back at the same clinic in medical records. And by the time I left that group, a solid 10 years later, I was director of operations.
Well, it's relevant to our conversation today because I mean, you literally learned this business from the ground floor, the kind of work that a mom can give to a 13-year-old and not worry about the labor laws. Now you're running a very substantial group and want to talk about the challenge that leaders face as they start to drive change because you've got lots of change initiatives that are going on, but they're that is the challenge for a leader. Talk a little bit, give folks a little bit of a sense on some of the initiatives that you're working on, and we'll work back into the psychology of dealing with change, both with the provider side of the organization and the support staff.
So when I'm looking at change, especially for myself, I'm relatively new to this group, and I've had many times in my career where I've been put in a leadership position, new to a group, and you're assessing the landscape. And the first thing you do is say, okay, what's working, what's not working, and what might we need to do to motivate the group to kind of reach that next level, because a lot of times in leadership you're brought in as an agent of change,
Right.
that can be a bit daunting because that can be threatening to people, and a lot of it is a game of inertia. You have to figure out where the group stands if that change is threatening to people.
Right.
So a lot of times I start by looking at, do people have the tools that they need to do their job? So a lot of times I'm looking at our end users, or have
Yeah.
we looked at do we have modern contracts, vendors, all of those things and those support services that could be obstacles to letting people perform and act efficiently as we expect of them. So I think
Right.
that's one of the first areas that I look at is, let's look at the landscape at the baseline. Do we have what we need to do for people to do their job efficiently?
Yeah. It's really hard to ask somebody to, cut wood and we didn't give them a good axe. Right.
Right.
So in the tool side is where you start. You're looking at that again, both on the providers in your organization that are, directly seeing patients and then everybody around them that makes it happen. How do you find differences in that question on those two sides of a practice, the clinical side and the support side, front desk, RCM, finance, the whole nine yards on getting everybody the right tools?
When you're looking at physicians and staff, you have to realize that you're talking to two different groups, and you have to know how to articulate to two different groups based on what their needs are, what they're trying to get out of it. And one of the things that I find for physicians is data matters. It matters a lot to them. So,
Right.
just going off of a gut feeling isn't enough for them. And a lot of times, especially in private practice, they might have been running on a gut feeling or just
Right.
historical information, and they don't know the validity of that information. So, there's also a strong tie to tradition
Right.
and respect for culture, trying not
Yeah.
to shake that up too much initially and being mindful of what that looks like. And so I try to be really intentional with how I deliver my messaging because sometimes it can be offensive. The idea of change can be offensive because people might think you're challenging their competency. So I think at a base level, I try to make sure that I'm navigating, especially those initial conversations,
Right.
navigating with respect, regardless of who the end group is. I think that's really important.
Yeah. Hey, it's interesting. You put a couple things here I want to unpack. So sometimes we don't really think of data as a tool, right? We think about the EMR, we think about, does somebody have the equipment in the room, those types of things. But to run a practice well, data really is as important as any of those tangible physical things. What have you found to be some of the challenges in getting people who maybe have historically not operated in a data driven way? It's kind of whoever can yell the loudest wins. What are some of the challenges in leading into that kind of a change to bring data to the center of the decision making process?
I think making sure that it's the right data. A lot of times you can work with a group and let's take your financial reporting, whatever that looks like, and reviewing that. And one of the first questions I have, especially at the physician level, is who understands this? Is
Right.
this put in a way that you all actually get?
Right.
Or are you
Right.
just looking at P&L and balance sheets and all of these things, and you're not really understanding what the bottom line is? And is
Right.
there something that I can do to translate that information or give you something that's actually understandable? And
Right.
a lot of times I find taking all of that dense financial information and turning it into a narrative is much easier for physicians to understand and giving a summary, a lot of times graphs, things that people can actually visualize, but having strong key performance indicators instead of
Right.
just saying, hey, here's all of our accounting stuff, because physicians oftentimes they're not accountants. And so I don't
Well, you have
expect
the
them to
same
be.
problem on the rev cycle side, right? A lot of information. You can just turn the fire hose on and the rev cycle team can say, well, we told them. And it's like, yeah, we poured water on a rock, but they didn't understand what conclusions you were trying to get. All
Right.
right. That's about after tools. You talked about culture. So let's talk about that one because that's where we start. The tools are a little more tangible. Like, what do you need? Can we afford it? How do we get it? It's a pretty straightforward conversation. Now you start getting into culture, and there is this tension, right? The culture historically that got us here, we want to respect, but it actually may be part of the blocker in getting us to where we need to go. So talk about stepping into that place where I've got respect for the past and I've got what we need in the future and the
Right.
psychological, social parts of that question.
Right. I mentioned earlier that inertia, it's a game of inertia. And I think a lot of times bad or negative inertia hides behind this facade of tradition. And so
Right.
people say, this is how we've always done it. This is the comfortable way. And so
Right.
navigating that and really trying to identify who's on board, who are your early adopters, who are going to be the people that are going to fight regardless of what the initiative is. And then who are the people that are the historians of record. And I feel like you
Yeah.
find that a lot with the physicians, the senior physicians that have been there for a long time. Those are the ones who might say, we've tried that process already, or I don't know how this is going to work. And finding a tactful way to say, well, let's try it from this angle. And
Uh-huh.
again, from a physician level, providing the data and having conversations about, well, what are we really talking about? Are we talking about growth, utilization, reimbursement, and making sure that you're being really clear in how you're attacking all of these challenges? But yeah, I think you got to know your audience, and you have to know how to articulate this so that people feel safe having the conversation.
Yeah. I love the historian of record phrase because it's an incredibly valuable person, especially when you step in new. But if the historian of record is also resistant to the change, they can like try to leverage that I'm the holder of the history, therefore my opinion's right. And it's like, well, you're holding the history is valuable, but that doesn't give you a trump card for how we go forward. How do you deal with the historian of record who likes the history and doesn't want it to change?
I think there's a balance with those kind of personalities, and what I try to do is I really value having one-on-ones with all of my physicians because, as I always tell everybody, the the organization, yes, at the core of it we are meant to take care of patients, but we're also a business and we're also a brand. And every physician within that is their own brand. So when I get the historian of record and I talk to them, I say, What are your challenges and where do you struggle?" And recently I had a conversation with one of our amazing physicians, and efficiency is where he struggled. So we ended up dabbling into the AI conversation, which is something he hasn't done so far. And I knew that was going to be a threat to some of his normal sensibilities, but
Okay.
understanding where they're coming from. He wants to relate to patients. He doesn't want to feel like the computer is between him and them. But then
Right.
understanding how, hey, we can speed you up. We can actually make you more connected to more people. So, really
Right.
just trying to put myself in their shoes and help them understand how we can move this process forward without threatening what's
Yeah.
really the cultural core of the group.
Yeah. One of the things that you often hear with new practice executives in a position like yours, they're going through the interviewing process, and the physician owners say, "Hey, we've got these challenges. We need to go from A to B." And then they get in and they find, "Hey, doc, you're the problem." Right. On one hand, as an owner, you see what we need to do with the business. On the other hand, as an individual provider, you're the sand in the gears. You got any of those? And if so, they would remain nameless, of course. And if so, how are you trying to help them connect the dots between the change they see is needed on one level and their personal uncomfortable change that's got to be part of the process?
I think that in the interview process or when you are onboarding with the group, normally people are talking about an idealized state of what they want the organization to be.
Right.
Whether they're really contributing to that is another conversation. And I think you should always go into these roles expecting, look, there's skeletons in the closet. There always are.
Right.
And if you luck into a situation where there's not, then good for you because I don't know where that exists. But I think navigating that and reminding the group to say, hey, what was the original goal? What was the intent? Was it growth? Was it stability? Was it modernization? Well, here are the real obstacles that are preventing us from getting to that stated goal
Right.
and realizing this isn't an overnight kind of thing. With this, it takes time to make a paradigm shift. And a lot of times these are paradigm shifts. Those
Yeah.
don't happen overnight. And if you try to make it happen overnight, things are going to fall apart. That's just too much instability and people don't respond well to that. So I think reminding the physicians, yourself, the group of the
Right.
stated goal,
Yeah.
and then saying, "Okay, let's take some baby steps." And sometimes it's multiple meetings, but you say, "Okay, we took a small chunk out of it this month. Next month, we're gonna do the same."
Right. Um, I want to talk about a group that is very particular, important, critical in the change process for the practice, and that is the administrator's key lieutenants. Right. We talked about the physicians, we talked about the clinical staff, we talked about the folks at the front desk, rev cycle, finance, but a person sitting in your chair has a handful of key lieutenants that really kind of make the machine go. And that group is critical to any change process, critical to making progress in the business. But they too are human beings with personal needs, wants, and fears. Talk about how, as you stepped in as a new administrator, how are you approaching your key director, vice president level folks that report to you?
Yeah, you have to listen. And one thing that I learned early in my career, and I've always framed it as what I thought was one of my strengths, but then I learned it was also one of my weaknesses, is I don't really get a lot of change fatigue.
Yeah.
So, I'm perfectly comfortable living in the ambiguity and moving us forward, but that doesn't mean that everyone that's following me has that same resilience. So, I really have to make sure that I take time to pause and make sure that I'm not
Yeah.
going 100 miles per hour and dragging my team behind me. So, there's a
Mm.
lot of opportunities where I need to sit and listen, and I might have a great idea, but I put the projects down. We as a team meet on a regular basis and we put the projects down. We put the ideal timelines when we would like to have them implemented. And then having an honest conversation of like, all right, is this a this year problem or
Yeah,
is this a next year problem?
right,
And even if I think it might be a this year problem, being cognizant enough to say, you know what, let's push that back a little bit. Let's check some things off of our list instead of
right.
just having this outrageous growing list. And that I think provides people a little bit of psychological security,
Yeah,
so that they know that, A, I'm willing to listen to them. And again, that my passion for change,
right.
as I've been assigned to do, isn't going to override their comfort and their sensibilities when, many of them have been with the organization for a long time. And I need to respect that.
Yeah. I think that's really good advice for leaders because people who end up in leadership positions are pretty high capacity and they like to go pretty fast. They should be the setting the pace of the organization. That's part of what leadership means, right? Because
Right.
inertia is heavy on the other side. But recognizing, and I think where maybe some leaders get in trouble and forget as they forget they are way out on the distribution curve of a higher capacity for change fatigue, a higher comfort level with change. And so, yes, I want to create tension, but I can't pull it so hard it breaks. I think that's a good insight. Final question. A year from now, you're reflecting back at what's happened at Denver Arthritis Clinic. What do you think will be one of the biggest things you've overcome in the change process that you'll say, "Okay, that was hard, but that's a good win. We got from A to B." What do you think is gonna be one of your biggest victories in the next year?
I think the biggest victory and the thing that I always look to do, especially if you're the new kid on the block, is buy-in. Really getting buy-in from all corners, and that's physician buy-in, that's staff buy-in, because there just has to be trust. And it's easy for me to come in and be granted a title of leadership, but informal authority is so much more powerful
Right,
than the title. And so I think people need to trust that I'm here to support them. I'm here to lead. I have a very strong servant leadership model. So, my success is when the group collectively looks back and says, what a year, but look at what all we've done. And then they feel like they had a sense of trust in me to say, hey, he really led us through this. What's next? And so that hopefully the culture is pivoted to a more progressive mindset. So then we can start looking at maybe more ambitious challenges and things that we would like to do. So really setting a platform so that the group does have a cultural shift towards being progressive and motivated, and that they see me central to that, and that they can trust me to lead them through.
awesome. Yeah, buy-in is fuel that worked for a lot of years, doesn't it? Awesome. Andre, thanks for sharing your story. Congrats on the new position.
Thank you.
And best of luck to you and the whole team at Denver Arthritis Clinic. Thanks for being on Vital Conversations.
Thank you so much. I appreciate it.
Thanks for listening to today's episode. For more conversations like this, subscribe wherever you listen to your podcast. We'll be back soon with another discussion focused on what really works in healthcare.